Welcome to This Explainer. Today we're running a rapid-fire drill on clinical urology. We are breaking down absolutely crucial, high-yield exam pearls to really test your diagnostic chops. Let's just dive right in. Clinical urology exam pearls. We're going to throw real-world clinical scenarios right at you, starting with oncology and trauma. Let's see if you can spot those key indicators on the fly. Okay, question 11. What is the standard definitive treatment for a histologically confirmed T2, meaning locally muscle invasive, bladder carcinoma that's been identified on a transurethral biopsy? Is it A, a repeat localized resection, B, partial cystectomy, C, radical cystectomy, D, radiation therapy alone, or E, systemic chemotherapy alone?
The correct answer is C, radical cystectomy. And here's the reason why. That T2 staging is an absolute game changer. It denotes that the tumor has literally invaded the thick detrusor muscle. Once you have detrusor invasion, localized endoscopic resections like a TURBT, they just aren't curative anymore. The standard of care mandates a radical cystectomy, removing the bladder and surrounding structures, plus the pelvic lymph nodes. Now, for an exam pearl, what if your patient just isn't a surgical candidate for such a massive operation? Well, your go-to bladder-preserving alternative is a combo of external beam radiotherapy and radiosensitizing chemotherapy.
Moving right along to question 12. What is the most appropriate management strategy for a primary, low-risk, superficial, or non-muscle invasive TA bladder tumor? Your options: A, complete transurethral resection of the bladder tumor alone. B, intravesical BCG immunotherapy. C, systemic chemotherapy. D, radical cystectomy, or E, external beam radiotherapy?
The answer is A, a complete transurethral resection of the bladder tumor, or TURBT, alone. The reason? Well, by definition, a TA tumor is a non-invasive, low-grade papillary tumor. No carcinoma in situ. So a meticulous TURBT alone really is sufficient, followed by strict cystoscopic surveillance, of course. A quick exam pearl here. You want to save that intravesical BCG immunotherapy for your high-risk cases. Think high-grade T1 lesions or flat carcinoma in situ, where you actually need to trigger a massive localized immune response to prevent it from coming back.
Next up, question 13. A 60-year-old patient presents with painless gross hematuria and the occasional passage of blood clots in his urine. Evaluation identifies a distinct bladder growth. What is the most appropriate next step in management? A, observe and repeat urinalysis in 3 months. B, start empirical antibiotics. C, perform an MRI of the pelvis. D, radical cystectomy. Or E, transurethral endoscopic resection of the mass.
Correct answer is E, transurethral endoscopic resection of the mass. Here's why. Listen, painless gross hematuria in any adult over 50, you have to assume it's a bladder tumor until proven otherwise. Immediate local therapy via TURB doesn't just control the bleeding, it gives you the vital tissue architecture you absolutely need for formal grading and staging. And your exam pearl, remember the painless hematuria mandate. You must do a complete evaluation. That means a flexible cystoscopy for the bladder itself and a CT urography to evaluate the upper tracts, so the renal pelvis and ureters.
Let's hit question 14. Which of the following is a well-recognized metabolic and electrolyte abnormality characteristically encountered following a ureterosigmostomy? A, hypochloremic metabolic alkalosis. B, hyperkalemic metabolic acidosis. C, hyponatremic metabolic alkalosis. D, hyperchloremic metabolic acidosis. Or E, hypocalcemic metabolic alkalosis?
The correct answer is D, hyperchloremic metabolic acidosis. The reason is a continuous electrolyte shift. When ureters are implanted directly into the sigmoid colon, the urine just sits there. The colonic mucosa acts like a sponge, actively reabsorbing large amounts of ammonium and chloride while simultaneously secreting bicarbonate out. That constant shift drives the hyperchloremic normal anion gap metabolic acidosis. And an incredibly important exam pearl, due to chronic nitrosamine exposure from mixing urine and feces, these patients face a staggering 20-fold increased risk of developing adenocarcinoma right at that anastomosis site, usually years down the line.
Question 15. A patient develops a neurogenic bladder following an acute trauma to the spinal cord. What is the most appropriate initial urological management during the phase of spinal shock? A, insertion of a permanent suprapubic catheter. B, observation and wait for spontaneous voiding. C, clean intermittent catheterization. D, administration of parasympathomimetic agents. Or E, immediate urinary diversion surgery.
You want C, clean intermittent catheterization. Why? Well, during that initial phase of acute spinal shock, the bladder is totally detoned. It's flaccid, it's akinetic. To protect those kidneys from high-pressure reflux and to prevent severe overdistension injury to the bladder muscle itself, you've got to systematically empty it manually, usually 3 to 4 times daily with clean intermittent catheterization. For your exam pearls, keep the upper versus lower motor lesions straight. Once spinal shock resolves, an injury above the sacral center results in a spastic upper motor neuron bladder, but an injury at or below the sacral center leaves the bladder permanently flaccid, requiring long-term catheterization.
Question 16. A 25-year-old female presents to the urology department with complaints of burning micturition, accompanied by a fever of 101 degrees Fahrenheit and leukocytosis. She describes severe, localized pain that is referred directly to her labia majora, along with a sharply increased daytime urinary frequency. What is the most likely cause? A. Renal calculi. B. Bladder calculi. C. Acute appendicitis. D. Ectopic pregnancy. Or E. Ovarian torsion.
Correct answer is B, bladder calculi. The reason comes right down to mechanical irritation. As the stone physically rolls over the highly sensitive bladder trigone during daytime ambulation, it causes intense mechanical friction. And here is your exam pearl, the vesicle stone pain signature. That friction creates a sharp pain right at the end of micturition, known as strangury. In females, it's referred directly to the labia majora. In males, it shoots to the tip of the penis. And of course, the stasis from the stone frequently triggers acute bacterial cystitis, which totally explains the fever, the burning, and the high white count.
Flowing right into question 17. What is the most appropriate, minimally invasive treatment for a 15mm symptomatic vesicle or bladder stone in an otherwise healthy 25-year-old female patient? A. Endoscopic cystolitholopexy. B. Open suprapubic cystolithotomy. C. Extracorporeal shockwave lithotripsy. D. Long-term antibiotic therapy alone. Or E. Observation and increased fluid intake.
It's A, endoscopic cystolithocapsy. The reason is simple. It is the absolute treatment of choice for a stone of this size in a healthy patient. You introduce a cystoscope transurethral, fragment the stone right there in the bladder lumen using a mechanical, laser, or pneumatic lithotripter, and then evacuate all the debris. Boom. No open incisions to worry about. As an exam pearl, when do you actually use open surgery? You really only reserve open suprapubic surgery for massive or super hard stones. Think over 4 centimeters. Or if you're dealing with a severe urethral stricture that physically blocks your scope.
Let's look at question 18. A 52-year-old male complains of intermittent, painless, gross hematuria for the past 6 months. A local clinician previously suspected a simple blood clot in his bladder and treated him empirically. What is the primary diagnosis that must be suspected and ruled out? A. Acute bacterial cystitis. B. Benign prostatic hyperplasia. C. Bladder tumor. D. Nephrolithiasis. Or E. Interstitial cystitis.
The answer is C, bladder tumor. Here's the reason, and it's a critical one. Urothelial cell carcinoma is the big bad here. The fragile neovascularization of a tumor can cause significant episodic bleeding that forms intraluminal clots. So it can very easily mimic primary hematological clots. Your exam pearl? The malignancy screening protocol. Never ever attribute unexplained, painless, gross hematuria in an adult over 50 to a benign clot, an infection, or blood thinners without definitive screening. You must screen with a flexible cystoscopy and CT urography. No exceptions.
Almost done. Question 19. A young female patient complains of severe urinary incontinence. She notes that the moment she feels the urge to urinate, she involuntarily passes urine before she is physically capable of reaching the restroom. What specific type of incontinence is she suffering from? A. Stress urinary incontinence. B. Urge urinary incontinence. C. Overflow incontinence. D. Functional incontinence. Or E. Mixed urinary incontinence.
Correct answer is B, urge urinary incontinence. The fundamental reason here is detrusor muscle overactivity. The bladder muscle is just contracting prematurely and involuntarily during the filling phase, which completely overwhelms normal urethral closing pressures. For the exam pearl on medical management, your first-line approach usually targets that overactive muscle directly during storage using antimuscarinic agents like oxybutynin or sulfenacin. Just be absolutely sure to rule out local irritants like an infection or carcinoma in situ before you label it as idiopathic.
And our final one, question 20. A young female patient complains of bothersome urinary incontinence. She states that her urine leaks in small bursts, specifically during sudden episodes of coughing or sneezing, and she forces herself to void frequently to manage it. What type of incontinence is she suffering from? A. Stress urinary incontinence. B. Urge urinary incontinence. C. Overflow incontinence. D. Functional incontinence. Or E. Total incontinence.
The correct answer is A. Stress urinary incontinence. The reason? Sudden spikes in intra-abdominal pressure, like from a cough or sneeze, are completely overcoming an incompetent or weak urethral sphincter. And importantly, there's no associated bladder muscle contraction happening here. Exam pearl time: if pelvic floor physiotherapy fails, you can look at surgical correction. Procedures like mid-urethral transvaginal tapes are used to restore support right under the mid-urethra, compressing it shut during that sudden physical strain. And that covers our rapid-fire explainer today. From oncology staging to the fine details of urodynamics, the clinical presentation is always a complex puzzle. So the real question to leave you with is, how sharp are your diagnostic instincts going to be when that next unexpected case walks through the door? Thanks for drilling with us, and keep those exam pearls ready.